Get going. Welcome back, everyone. We are going to now get to the heart of the meeting with our voting questions. Remember, if you have any problems with Slido, please reach out to Maddie for this. So we will start with the first part, which is special ethical considerations and priorities. This is now moved to the front of our voting, where we want to really recognize the importance of this in our deliberations. So if we can go to the first question, and I especially hope we can get input from our patient experts on this. So first question, are there any particular obligations to people with this condition because of disease severity and or unmet need with current available therapies? And I'll reach out to Jason or David in a second, but just as a reminder, this is and or. So if any of these apply, and we all may have slightly different thoughts on what is considered an obligation, but it's kind of the diversity of our committee that's going to help us try and come up with a really rounded perspective on this. So Jason, if you've rejoined, or David, if you want to just guide us through this a little bit and remind us.
Sure. I think Jason is trying to figure his way back on at the moment. So if you look at table 14 in the evidence summary, you can see in terms of unmet need, the shortfalls that were presented by Brett earlier, and that these show that this is a condition with what's available as current therapies, with degrees of harms to life, both in terms of quality of life and length of life, similar to really serious conditions such as multiple sclerosis, and that there are large shortfalls and large unmet need. And
Great.
Great to hear from patients on that.
Yeah. Tony or Samantha, did you want to, talk a little bit about kind of what the realities of this disease is and the impacts it can have?
Sure, I'll start. Thank you for the question. Substantial impact. I think especially as it's been noted that it is a silent killer. But when it does hit, it hits pretty hard. And the realities of that being that you run a normal course of life until you don't. And it's kind of like running into a wall, if I can explain it the best way possible. Even up until where my EGFR was at 4, I was still kind of mobile and doing some things, even with some brain fog. But once you get down to that level, everything kind of halts, even your daily, routines and walking and experiences, or your ability to critically think or function are just heavily clouded. So, in my mind, the idea of preventative experiences or preventative medicine or preventative approaches are highly sought out and highly needed by those that can hopefully find out that they have this rare kidney disease earlier in life so that they can work towards some of these preventions, where in my case, even had there been that when I was biopsied and officially diagnosed, there were no remedies or cures other than steroids, which, by the way, I chose not to take that path because of the lack of evidence. And the evidence that was put out there was not good, based on my research and conversations with other patients, especially at high doses. So I chose to go down another path.
Great. Samantha, did you want to add anything?
Sure. So I was actually diagnosed in 2022 at the age of 25. And as you can imagine, being a woman in your mid 20s, it's getting a diagnosis like this is like truly life altering. I was in college, studying to be a forester with like the anticipation of pursuing a career as a park ranger, and I've since had to kind of pivot that. Obviously, being out in the backwoods isn't something that's super conducive to people with an autoimmune condition. And then this was also ultimately like what made the decision for my husband and I to not have children. Both, one, because of how detrimental this could be for my body. Two, I am of Asian descent, and I don't know if I could possibly pass this on to children. And then three, I like something that was probably the most difficult for me is like struggling with knowing I have this, and then if I bring a child into this, they would have to grow up knowing that their mother's sick. So that was something that greatly impacted me there. Unlike Tony, I don't know if it was maybe just because of my age or just, this is so impactful. I didn't really know that I could not do steroids. I was diagnosed, I was spilling 8 grams within a week of my biopsy and diagnosis. I went on Cytoxin and Solu-Medrol and eventually prednisone. And the the side effects that I experienced from that were very, very intense. And then also I took Nefecon and I also experienced like an intense amount of side effects. And this was before there was other alternative therapies. This wasn't necessarily because that's what I picked. That was my only option. And being on those two back to back was a lot on my body and a lot for me socially. Like I am in college, I couldn't go out with my friends the same way. I like quite literally couldn't stay up. It impacted a lot of my test scores. I had to take, substantial time off of school and away from my education. So from like the perspective of being diagnosed as a young patient, it's been very career altering. Like I've pretty much had to change the whole course of what I thought my life would be.
Thank you both. I think very quickly we have a great sense of kind of the impact. Do people have other questions before we move on to a vote on this or comments? Great. If we could put the questions up and everyone can cast their votes. Typical obligations, some added obligations, or substantial added obligations. Great. I think everyone has voted. So we have 2 with some added obligations and we have 7 with some added obligations and 7 with substantial added obligations. Let's move on to the next question. Are there particular obligations to people with this condition because it disproportionately affects those from racial, ethnic group that have not been equitably served by the healthcare system? And we have the same options. Jason, do you want to say anything about this?
Sure. Yeah, I think the relevant information here is also in table 14 in the row below where David had flagged earlier. Prevalence estimates by race and ethnicity differ in different settings. In the United States, IgAN is less prevalent among Black people, more prevalent among Hispanic people, and extremely much more prevalent among Asian individuals.
Any questions or comments about this before we move on to voting? So let's everyone cast their votes. Great. So we have 2 with typical obligations, 11 with some added obligations, and 2 with substantial added obligations. Moving on to the next question 3. Apart from issues around disease severity, unmet need, and race ethnicity, are there other particular obligations to people with this condition? And sometimes there aren't any, in which case this would be kind of a typical obligation. If people feel strongly that there are some that we should be considering, please vote. Please bring them up now. We should be voting on a specific issue. And if there are no specific issues, I think that we haven't already covered with the other two questions, this would be typical obligations. Any comments or thoughts? So I think we're going to go to the next question. So the number 3, please cast your votes. Okay, so the majority are saying typical obligations.
As we
All
move
right.
on, Lisa, I'll just chime in just to remind only CTAF members should be voting. We know that there are others who have access to the link. And so there should just be 14 votes happening. Thank you, everybody.
Yeah, this is very important. Okay, moving on to the clinical evidence. Looking at the first question, and I'm going to say as a overarching reminder, we are going to discuss questions 4, 5, and 6 all at the same time. So question 4, is the current evidence adequate to demonstrate that the net health benefit of sibeprenlimab is greater than that of no specific immunomodulatory therapy? Sorry, we're going to ask then the same question with respect to atacicept, and then finally with respect to Nefcon. So all 3 of these questions are comparing the therapies under consideration versus no therapy at all, essentially versus placebo. And Jason has previously presented the evidence on these as B+ across the board. Jason, I don't know if you want to remind people or share the right tables where that was reviewed. And if anyone has any questions on any 3 of these, let us know. We have kind of somewhat more controversial votes to come.
Can you just remind us of the time frame for this question?
What do you mean by that, Rita?
Yeah.
Like net health benefit over the next 6 months, over the next year, over the next 5 years, over the, like that. That's
the totality of the evidence that's presented on whether or not you think there's adequate evidence of a net health benefit for the drug.
Yeah, Jason went through the duration of the data we have for this. And so I think that's, I think obviously we don't have lifetime data. None of us would still be alive if we did. So you have to take into account what the data we have and over the duration of the totality of the evidence we have, as Sarah said.
Yeah.
Any other?
I just wanted to say, yeah, exactly. B+ ratings, as Dr. Murphy had articulated, and then there's also evidence. The underlying evidence for those are from randomized control trials. So the subsequent votes we're going to get to, there aren't trials comparing these things. We do have trials that compare these 3 interventions against placebo, which we take to model the effect of no specific immunomodulatory therapy. And their underlying data for that are in subsequent tables. You can see especially in table 4, which is on page 7. This is the eGFR slope, and table 5 with the proteinuria data. And there's also information about harms from key trials. Again, this is limited to information that we have from trials. Table 6. I think Sanket has a question.
Sanket, yeah.
Thanks so much. And so looking at those data, urine protein creatinine, eGFR, as we discussed, we don't have, for lack of better terms, sort of hard clinical outcome data, which would take many years to get. So should we be generally accepting that the urine protein creatinine, the eGFR slope are well accepted, that we think that based on these surrogate markers that we are going to see hard outcomes, less patients on dialysis, less patients with advanced renal failure, less patients with MIs, etc.?
Yeah, I mean, I think that's ultimately for you to decide. But as our experts spoke to this issue before, as surrogate markers go, these are very good. And obviously some of the approvals are based on them. So. Are folks ready to vote? We will vote on question 4 first, and then we can have discussion afterwards. So is the current evidence to demonstrate sibeprenlimab greater than no therapy? Yes or no? Waiting for one more person. Oh, maybe that's me. So we have 14 yes and 0 no. Moving on to the next question. Is the current evidence adequate to demonstrate the net health benefit of atacicept is greater than that of no specific immunomodulatory therapy? Waiting for one more vote. Maybe you haven't hit your sent button. There we go. So we have 13 yes, 1 no. And then the sixth question, is the current evidence adequate to demonstrate that the net health benefit of Nefcon is greater than that of no specific immunomodulatory therapy? Waiting for one more vote again. There we go. So we have 14 yes and 0 no's for that question. So now we move on to the comparison with glucocorticoids for each of these agents. So looking at the first, is the current evidence adequate to demonstrate that the net health benefit of sibeprenlimab is greater than that of systemic glucocorticoids? So Jason, I don't know if you want to remind us of the data on this, and I suspect there might be more discussion on this.
Yeah, yeah, this is going to get a little more conversation maybe. So again, from the evidence summary, table 1, we issued P/I. So just to remind, that's promising but inconclusive evidence for all of these comparisons. The underlying data again are in the same tables. So this is in table 4, table 5 for benefits of these different agents, and then the harms are summarized in table 6. Just to be clear about this, these things have not been compared. These comparisons that you're being asked about, there's no randomized comparison of these comparisons. You have heard from our report, from the clinical experts, from some of the public commenters that there's a lot of concern about the effects of systemic glucocorticoids as side effects, and that was influential in us giving it a promising but inconclusive rating, but these agents have not been compared against each other. And then with the side effects of the newer agents, it's a little bit complicated, but Nefcon does have some steroid typical side effects, perhaps less, but again, there's no randomized head-to-head comparison. And then synpredlimab and etacicept don't have safety signals that are concerning in the trial data, but to the point, it's a relatively short trial. We don't know what would happen over many, many years.
Great, Jeff.
So just to be clear, the vote here would include the potential for side effects on the corticosteroids as an alternative, just to be clear, right? I mean, it's not just, is this
Yes.
better, but how does it compare to, your alternative side effects, even if the efficacy is not different?
Yeah, net health benefits would merge both of those ideas. Yeah.
Other comments or questions? Waiting for one more. Great. There we go. So we have 9 yes and 5 no. Since we have a little bit more of a split vote on this, I don't know if any of the people who commented or voted no or yes wanted to comment on why they voted as they did. This committee is silent. That's difficult to imagine. Jeff.
Yeah, I'm willing to say it. You know, if you're talking 35 milligrams of prednisone a day, that's pretty difficult treatment. And so if you've got something that, as was said, there we don't have any indications of particular acute side effects, you know, people loathe to be on steroids, and that's a pretty substantial dose. It's not 60 a day, but it's pretty substantial. So my thought is, we know it's better than placebo. We don't know if corticosteroids really are better than placebo because there wasn't really a great comparison, and we know this has fewer side effects. So I'm team anti-steroids. Let's put it that way.
Great. Sanket?
Thanks so much. And I just want to note it's so helpful to hear from our patients who are living with this disease. I think as a clinician, I certainly know and see how terrible systemic steroids are, and it's very helpful to hear from the patients. I voted no, however, because I think the question is really asking, is the current evidence adequate? And I don't think that it's adequate. As Jason pointed out, we don't have randomized data. We're trying our best right now to compare, but if you're not comparing as best you can, I don't think that that's beneficial. I also, during the break, I also spent some time trying to look at the KDIGO guidelines to understand in detail why the steroids are recommended, systemic steroids are recommended second. They recap the evidence, but it doesn't seem clear to me as someone who's read evidence closely for a long time. I still can't quite tell why they're in second position there. And so I think we just need robust comparative data in order to be able to, for me specifically, to be able to vote that I would feel confident.
Thanks. Sanket. Say.
Yeah, I feel like Sanket said pretty much what I was thinking. I voted no as well. And I think as a clinician, I think all of us, all clinicians have had experience of patients on chronic steroids, and the amount of impacts that it has on patients in terms of muscles and bones and skin and cardiovascular, it is terrible. And I kept thinking about, these drugs, we have data for just a couple of, a year. And we're thinking about potentially patients needing these for many, many years. And I really ended up at the same place that Saket mentioned. There's like, I feel like it is incumbent on the manufacturers to provide us adequate data. And I think it was, in my mind, a huge strategic mistake not to compare against steroids, because that is, it feels like, if not, it is something that is commonly still used. So ultimately, I felt like the bar of evidence adequate.
Say you froze for a bit there. Maybe Joy will move on to you because I think Say is frozen.
Like it. So I really feel both sides of this discussion, and I was a bit torn about it. I completely agree that we need more comparative evidence. However, it's a standard problem that we confront with almost every new drug. No manufacturer wants to compare their drug to something that might even work a little bit because they can see a better signal if they compare it to placebo. And the reason I voted yes here was really exclusively about, I think the evidence is adequate that the side effects of systemic steroids are severe. I don't think anybody has a question about that. So, given the evidence at the moment and the urgency of this problem, I feel like there's two issues, and one of them is having more long-term information about these new compounds, and the other one is cost. But as far as side effects go, I'm persuaded.
Great. Thanks, Troy. Dr. Wadhwani?
Hi, I just had a quick comment, and I just want to be clear about the fact that systemic steroids are not the comparator in these clinical trials because they are not the standard of care. And all regulators agree, and that's why in no phase 3 clinical trial was corticosteroids the comparator. So I just want to be clear that yes, it's used by some people because that's all they've had for decades. But that does not mean that that is standard of care. And obviously, in a clinical trial, the standard that's not used, it was compared to placebo, and for good reason. So that's just, I don't envy the challenge you guys are in right now with this vote. And I understand and, grapple with a lot of the same concerns about how do you make a decision about something that's long term when we don't have long term data. But John, please feel free to jump in here. I just wanted to clarify that corticosteroids have not ever been the standard of care.
So can I just ask a quick question myself? So if you have a patient and you have systemic glucocorticoids, you would do nothing rather than give those, if those are your only two options.
Well, we would give RAS inhibitors. We control blood pressure. We would not. I mean, I'm from the UK, which clearly this is a US. We do not use systemic steroids,
but
and in the nice, and we don't choose them because they're not standard. No, not unless there's in a very rare situation where there's a rapidly progressive glomerular disease, which occurs in less than 5% of patients. And steroids were not included in the NICE Health Technology Appraisal in the UK for exactly that reason, because they are not regarded as standard of care treatment for this disease.
And if Dr. Wadhwani could share as well, if she had the two options of nothing versus steroids, you would do nothing. Assuming you're doing RAS inhibitors and all the rest.
Yeah, no, I think it's a shared decision making with the patient. I think one thing we forget about is a lot of these patients have other comorbidities. For example, I have a patient in my office who I saw yesterday who's diabetic and has IgA nephropathy. Steroids are completely off the table for him. And so I think that in certain situations, if I had access to no other drugs, and the patient was having rapid decline in GFR, wasn't interested in going into a clinical trial. If we look at the last set of KDIGO guidelines prior to the new 2021 guidelines, they actually recommended clinical trials first before corticosteroids. And so that's how strongly nephrologists feel against corticosteroids, that we actually think it was better for patients to go into a clinical trial because the evidence in favor of corticosteroids is so poor. And I'm not just talking about side effects. So I do think that we just, need to be clear that it is not standard of care from my perspective. And I would not, there are certainly patients I have chosen to do just RAS inhibitor and no corticosteroids.
Can I just ask, didn't the KDIGO guidelines say to use steroids if you didn't have Nefcon available?
Yeah, so the KDIGO guidelines, and John, please again, feel free to jump in here, are international guidelines. And so we recognize the fact that, in the United States, we're very privileged to have medications that are not accessible elsewhere. So we do want to be cognizant of the fact that in other countries, they may not currently and may not for some time have access to these other drugs, and they may choose to, use corticosteroids in high-risk patients. But again, I think that the risk-benefit ratio needs to be strongly considered, and it's not always in favor of corticosteroids.
I don't disagree. I mean, I think the data for steroids are poor, and I'd love to see better. I wish we had better studies when we were looking at this, but at the same time, doing a placebo-controlled trial where the KDIGO guidelines say that if you don't have Nefcon available, you should be using steroids. But
no, we don't. So sorry, we don't say that at all. So we say that they are an option. We don't say you should use them. We say that there is data available that you can look at after a thorough risk assessment for toxicity, and these are something that have a body of evidence that you can review yourself, but we in no way suggest that this is an appropriate treatment option. And that's really clear. Now, the wording of the KDIGO guideline is very specific here, that it says suggest, which means that it may be appropriate in some patients. In your opinion, you may wish to use them, but we're not saying that they are a preferred treatment. And the way KDIGO is structured in terms of its recommendations is written in that way.
And so preferred treatment is a little different than saying it's not efficacious.
Yeah, so what I'd like to jump in if I could. I'd like to take a lot of this to the roundtable conversation. So I'd like us to go back to voting on the question. And I would like this. I'm really excited to dig into this with John and Shika in the roundtable, especially get the patient perspective into, because I think what we're hearing is all of this is happening. And we want to talk about what's ideal versus like what's practical. And that's a perfect thing for the roundtable. So thank you.
Great. Bob, do you have a comment that's unrelated or?
No, I've got a very related comment since we've got two more of these questions right behind this one. I'm a bit perplexed and mildly annoyed, and many of you are good friends. We're having an argument in the weeds about things that just aren't real. The patients have already expressed the voice here, both three individuals here. Corticosteroids are for the birds in this case. They're just cut and dried case. Okay, all of our experts, including ones that are voting no on this question, which I deeply respect their voice voting no, but they know too from firsthand real world their own evidence, and this to me is where we cross the line. Particularly among those terms, we've got clinical trials that are actually showing us something here that specifically addresses this question. We all have real world evidence that are actually telling us what the actual real answer is going to be here to this particular question. It's not that big a freaking deal, I don't think. And since we've got three of them here, I'm kind of interested in, and frankly, just again, perplexed that we're having such a discussion that to me is so far down in the weeds. Thanks.
Great. Thanks, Bob. I think that's a good segue into us voting on and reviewing the next question, unless Ralph had a. So, is the current evidence adequate to demonstrate that the net health benefit of atacicept is greater than that of systemic glucocorticoids? Again, I think the evidence rating was the same as from before. Any further discussion on this or anything you wanted to add, Jason? I think we're in a similar evidence situation.
Yeah, I just want to reflect in the setting of the uncertainties. I mean, a lot of what the voting panel is grappling with is sort of what the research team grappled with. I'll also just flag that Dr. Rind put the KDIGO language in the chat in case it's interesting to the committee.
Okay. So let's go on and
comment as well now. So I just want to make sure to flag both.
Yep, there's voting.
Lisa, your mute is on.
Thank you, Jeffrey. So we have very similar results to last time. We have 9 for yes and 5 for no. Let's move on to the next question. Is the current evidence adequate to support and demonstrate that the net health benefit of Nefcon is greater than that of systemic glucocorticoids? Any question or discussion around this?
I was hoping to ask our clinical experts, because we heard from Samantha about the side effects she got with Nefecon. And I, by the way, am on the side of the steroid side effects are horrible, and I would have voted with the yes on the prior 2 votes, but I'm less sure on this one. And I'm wondering, in clinical experience that's broader than one patient, what Shika and John's experience is with side effects with Nefecon. Are they much less than with systemic steroids? Can we count on that?
So in my clinical experience, yes. but there are some patients that will be exquisitely sensitive to the budesonide that's absorbed
What
and
we've
will
heard
have
from
many
the
of the side
patient.
effects we see with 40 milligrams of blood very often. So we always warn patients, but the majority of patients have very few side effects from the steroids. In my experience in the UK, I don't know, Shika, from your experience in the US.
Yeah, no, I think it's hard to know. Each patient is so different. Being a part of the trial in the open label phase, my patients had no side effects whatsoever. In clinical practice, similar to John, I have had a patient or two that have had some steroid side effects. I think what I wondered was, oh my God, if they're having these side effects to Nefecon, what would it have been had I given them prednisone? And I think some of this, may be related to what's their BMI going into, what are their other comorbidities, for example. So I think, we're happy that we have more than one option now to offer our patients and individualize. But a lot of patients are going to do very well and have no side effects whatsoever. So I think it's just a challenge for us to know going in which patient is going to go forward with flying colors, no side effects at all with Nefecon, and then, which ones might have some. I will say one thing, the patient of mine that did have side effects tried to, from the insurance company, still get another 9-month course approved because it was working. So was willing to live with those side effects, which was some weight gain and striae, but was sort of like, I'm happy to see the effect that this is having. So I would love to just keep going and continue to see benefit. So for what that's worth.
Thanks.
Great, thanks. Jeff?
In this case, I am hearing about systemic side effects, which are frankly not surprising. It is a corticosteroid. And I think it would have been worth in this particular study to have done a comparator to systemic steroids. So this is a different kind of steroid. And we don't have actual data. We have anecdotal data that it seems to be better tolerated. I'd like to have seen that. And so, I think on this one differently than on the others where we didn't see really any evidence of particular harm. This one we're hearing about it, we're reading about it, we see it noted. So I think this one actually is more challenging, as David had mentioned, and I kind of agree with that this one I would have liked to have seen a comparator versus systemic steroids because it does have some side effects from what the report said.
Great. Samantha?
Yeah, I could just clarify a little bit too. Like I did experience very, very intense side effects, but after completing the 9.5 month regimen I was on, I did receive a diagnosis of having a form of microscopic colitis, which may have caused me to absorb, more of the steroid that was like intentional. So similar to both Shika and John said, it could just be that I'm one of those people that's more prone to, these side effects, whether it's the steroids or not. Additionally, my doctor, she has 4 other patients with IgAN, and I'm the one with the most aggressive form. I know that I'm the only one that she's treated with steroids, just because of my case. So.
Great, that's very helpful. Thank you. Kavita.
Sorry, not Shrika. Samantha, I have just a quick question for you. And so if you were to do this again, you would continue being on the Nefcon, you had side effects, you had a particular contraindication as a result of it versus the steroids. I realize your choices are limited, but you're the real world experience.
Yeah, with the options that there are today, I actually I had a better experience on prednisone than with the Nefecon, and I'm sure that's not typical. You know, I don't think I would do steroids again unless it's truly my only option based on the time that I had on them. I gained close to 80 pounds. I experienced extreme stretching. Like I still have scars all over my body. It really, really altered my self-image as, as a young woman, especially. I wouldn't do it again, especially now that there's options. And even if there wasn't, I would have to be in a very, very low state in my journey as an IgAN patient to even consider it again. And it did work. I am actually stable now, and I'm still stable, so I'm very thankful for that.
On the NEFCON.
That's great.
From the NEFCON, yeah.
Okay. All right. Thank you. That's very illuminating.
Great. Any other? Are we ready to vote? Let's cast our votes. So we flip things here. We have 9 no and 5 yes. The next, we're going to move on to the comparison. I feel like from the discussion, we kind of got a sense of why people might vote one way or another, but if anyone has any strong things they want to throw out there. But again, I think we can discuss more at the roundtable. So maybe we will move on. Now we get to even trickier ones. Which intervention has the greater net health benefit? Sibeprenlimab, atacicept, or can't distinguish? Jason, do you want to discuss the data, remind us?
Yeah, I mean, we really have no idea at all. I mean, we sort of did insufficient rating. We can tell they both work relative to placebo. These two agents are new. They haven't been compared against each other. The data are, we can tell they both work relative to placebo, but that's not the topic of this question. You can see that the data from the different trials, again, not against each other in tables 4, 5, and harms in table 6. Same issue with both drugs. No safety signals that are concerning in the trial data that we have available, but obviously we don't know what happens in 10 years of taking the medicines.
Great. Is everyone ready to cast their votes? All right. We have consensus with 13, almost consensus. Can't distinguish. I don't know if the person who voted A wants to share why, but not necessary. Or the vote changed. All right, we now have total consensus. Moving on, which intervention has the greater net health benefit? Sibeprenlimab, NEFCON, or can't distinguish? Jason?
A similar story. I really can't tell. You can concoct a story why one might be better than the other, but they haven't been compared, and it would probably have to do with uncertainty, relative levels of uncertainty with time versus side effects that are demonstrated or not yet known. But it'd be very difficult to know in our estimation. The data are the same tables that I've referenced earlier.
Questions or comments on this?
I want to again ask our experts, if you had to pick right now, given the data, you've got GFR protection with Nefecon. You have virtually no side effects with the April and April BAFF drugs, and they look like they're working better. Which one would you pick?
Well, I will go first, and then John, I'll hear what you say. I just had a patient yesterday, offered everything. The patient and I agreed that sibeprenlimab was the right choice. And I think the reasons are, there's multiple reasons. Number one, the proteinuria reduction is better. Number two, the GFR data we have so far, we haven't been privy to the phase 3 data, but the phase 2 GFR data is a no-brainer between the two. Number three, the side effect profile that we know of so far, if you look at AEs and even though we don't have real-world evidence for sibeprenlimab, if you just look at the trial level data side effect profile, stronger it seems for sibeprenlimab. And then finally, if you think about the mode of action and the frequency, again, my patient's diabetics, keep that in mind. I wasn't going to go with a locally acting steroid, but 4 pills versus a once a month injectable. So I think, again, one person's opinion, but I think for me, now that this drug is available, it's something that we've been waiting for because it seems like it really is a completely different type of drug than what we've had so far.
But before John answers, I have a question to throw into the mix of this. So, and correct me if I'm wrong, but the big advantage of Nefcon is the side effect profile. Is there are there other intrinsic advantages other than the fewer side effects? And if there's no intrinsic advantages and we don't think systemic steroids work, do we think Nefcon works that well? I mean, we do have some data that shows compared to placebo it does. But anyway, I'll let John maybe address that when he chimes in if he has a preference in this scenario.
I mean, I agree with Jason. We haven't got good enough quality data at the moment. We need long-term GFR data to decide which of these is going to have the significant benefit. And I'm going to sit on the fence as a politician would. I would suggest we need the 2-year GFR data, and then we can compare apples with apples. If you look at the baseline characteristics of all these trials, the patient groups are almost identical. So you can look across trials because they're recruiting the same type of patient. And what I want to see is 2-year GFR, because it's the GFR that puts people on dialysis. And proteinuria is a good surrogate, but it may not be the complete story. So I want to see what happens with GFR. And also I want to see what happens, remembering Nefecon is a 9-month treatment. So for 15 months, they were getting no treatment compared to a continuous therapy. So what does continuous therapy do? But at the moment, I need to see 2-year GFR to decide whether any of these treatments is better than any of the others, to do this in a data-driven process.
But to the other question, does Nefcon do anything, has any advantage in terms of efficacy other than the lack of side effects? Is there any reason to think it would have any other efficacy advantage over systemic glucocorticoids other than side effects?
So in terms of, if you look at the testing data and you look at the NefIgArd data, they're very similar in terms of profiles of while on treatment, protection of GFR decline, reductions in proteinuria. When you stop both of those treatments, both return to how they were beforehand. So I think in terms of their mode of action or what they deliver, they're very similar.
Okay.
The big difference is you will never give repeated 6-month courses of steroids. Remember, in all of these cases, the effect wears off when you stop the drug. Mm-hmm. Just giving a 30-year-old 6 months of steroids is not going to fix the problem, because they're going to just go back to where they were in 3 years' time. They'll be 33. You can't give them another 6 months of steroids, then another 6 months. This is a nonsensical way of thinking about the treatment. You need a treatment that is safe and well tolerated, that you can give repeatedly or chronically, because that's how we'll manage the disease. So that's how I'm thinking about this in a slightly different way. But
yeah, I think that's why we're looking forward to the data on repeated cycles of Nefecon, because it's being given that day, but we don't have that safety data. Kavita, do you have another comment?
Just really quickly to piggyback, and I should know this, but were these drugs different in terms of mode of delivery, sub-Q versus oral, in terms of just, is there a difference there?
Nefecon is a tablet, and sibeprenlimab and atacicept are subcutaneous injections.
Okay, because I wonder if that plays a role into just from a patient preference standpoint. I know in MS, for example, it can have an impact on patient preference, oral, sub-Q, IV, those kinds of things.
Great point. Are we ready to vote? Let's cast your votes. Waiting for one more person. There we go. So we have 10 for cannot distinguish and 4 for A. Do any of the people who voted for A want to weigh in? Okay, maybe we'll go on to the next one, and then we'll do that vote. And if it's the same, we'll see if we can get someone to weigh in. Which intervention has the greater net health benefit? Atacicept, NEFCON, or can't distinguish. I think that conversation and the data are similar, so maybe we can just go ahead to the vote unless anyone has any strong comments. Okay, got 2 more people to vote. Still waiting for 2 folks to vote on this one. One more. There we go. So this time we have 3 and 11. So is anyone who voted for the drug over NEFCON as opposed to can't distinguish want to chime in? I will. So I voted for those. I don't think we have obviously any comparator data, but I'm struck a little bit by the inconsistencies in that we're being told steroids are terrible. They're not standard of care. You wouldn't even have that as a placebo group. Granted, the side effects are bad, but if you're comparing doing nothing versus steroids and the bad course of this disease, I feel like that people must think glucocorticoids are less effective than these other drugs, given the excitement. If the only difference between NEFCON and that is the side effect profile of them, because on the one hand we're being told that they're actually really bad drugs, so I don't know the excitement for NEFCON exactly for that. And NEFCON has to be given in repeated doses, we think, because as we were just told, the effect wears off. So it seems like the newer drugs would have an advantage. That's my reasoning around that. Joy?
I have somewhat similar reasoning. I mean, I think steroids are steroids, and are likely to have significant side effects over time. And as you mentioned, it seems like although it's being advocated as a sort of one and done for NEFCON, it probably isn't. So I went with, based on what we have at this point, kind of sense of the evidence, but we desperately need longer term evidence on these drugs, comparative studies.
Great. All right, let's move on. Because we got a bunch more questions left, and some of them are going to create more discussion as well. So now we're looking at benefits beyond health. And we have, to help inform judgments of overall long-term value for money, please answer the following questions about these 3 drugs when compared to systemic glucocorticoids. And as Sarah mentioned in the beginning, we don't always get to talk about the long-term value for money, so it's exciting that we get to in this instance. So, is sipaprenlimab likely to improve caregivers' quality of life and or ability to pursue their own education, work, and family life? Jason and our patients and clinical experts, if you want to have comments on this.
Yeah, we'd love to hear from the patients too. I guess our findings were that, dialysis is a big deal. So if it works, that would have a very large benefit on caregivers, but that it's, obviously in all these questions, you have to think about the evidence for which the comparisons are being asked for whether these things work relative to another agent.
I guess.
Go ahead.
Oh, I was gonna say, I guess I can chime in. Well, I've only had the experience of taking steroids. I was actually talking with another patient yesterday about like how exciting the evidence is about the subcutaneous injections and how freeing that would be to not have to take an oral medication every day, and the what I've heard from other people that I know that have participated in the trials or that are on atacicept, like they've said that it's greatly improved their quality of life when they compare it to other things. And then I don't do very well with needles myself, but from my understanding, they're like an epinephrine pen, so I wouldn't even have to see it. But if not, my husband gives me a B12 injection, once a month. And if he could just do that with this other thing, it would be easier than going to the pharmacy or, calling in for refills or whatever that is like for both of us.
Great. Dr. Wadhwani, and then maybe Tony, you can tell us your experience on your family with your dialysis.
Yeah, so thanks. Just real quick, I was going to say that I think you guys mentioned you did a big ICER thing on GLP-1s. And one of the things that I've noticed over the last several years is that patients going into clinical trials maybe 10 years ago not as excited to do subcutaneous injections, but now that Ozempic, Wegovy are all over, I think there's a lot more comfort with taking at-home subcutaneous injections. So I've been surprised in my own patients where I thought I was part of the atacicept trial. I thought it was going to be a hard sell for patients to want to go into that trial, but actually that was not the case at all. The other thing I just want to mention about quality of life, I do believe all of the trials are collecting the data. So I don't think that it's that they didn't collect the data or they're not sharing the data. The trials are still ongoing. That's why some of that quality of life data is not available. And then the other thing I just want to mention is that unfortunately the healthcare related quality of life instruments are not really designed for this population. And so the instruments, the questionnaires that are used, especially the kidney ones, were really designed for patients with later stages of CKD and dialysis. And we're trying to apply those to young people, earlier in the disease course that have rare kidney diseases or autoimmune diseases. So I think that's just one thing to keep in mind, that I don't know that the tools that we're using in these questionnaires are fully capturing what our patients feel. And I think that's come out between what Sam and Tony have said today. So I'll go ahead and turn it over to Tony.
Thanks for your comments. I'm on a quest to alleviate dialysis as best as possible for anyone. I think that going through the process is varied. When you talk about quality of life, for those that go through it, my dad actually went through dialysis going in 3 days a week, and it had a very big impact on him. He was on it for 7 years. I personally chose peritoneal, which I did at home, which is I liked it as a better option and saw what my dad had gone through, and it was a different process for me, but it was very intensive. You have to learn the manual way to do it. Then fortunately, you have a machine that works for you when you're sleeping at night. But it's very involved and a big strain on your caregiver. I've seen people, once again, is it better than current state? Sure. When I was in that state. Is it best state? Absolutely not. And so I think, anything that can delay that or alleviate that, I think anybody who's gone through it would tell you, yes, please. And so I would say that the caregivers on there, and I agree with what the doctor had shared around subcutaneous. I do think people have a different view on injections today because of that. I think there's still a lot of people that don't like needles, but they're looking at outcomes, right? And when there's no hope or outcomes, you look at things in a very differentiated way, especially when you don't have things in front of you that are a solution. And so the upside of having more solutions, I think, is good for us, but we're still in a state of there's a lot of variables that tell us, is it still hopeful? Are we going to get to the best outcome? And I hope those improved outcomes come, but based on where we're at today, we have to make the best decision as patients for what information we have in front of us.
Great. Say one last comment, and then we'll move on to the voting.
Yeah, I really appreciated what everyone talked about, especially kind of the patients. And I was thinking about how much I really dislike this question, because I feel like we don't have the evidence to be able to answer this question. I was kind of struck by what Tony said about hope. And I hope this works to prevent dialysis. And we don't have that data at this point. It seems to slow down the decrease in EGFR, which is I recognize it's impossible to do 20-year follow-up studies to actually, and we don't want to wait 20 years. So we're in this awkward situation, but to be able to say right now, if I felt like sibeprenlimab is going to help patients avoid dialysis, then yes, it would be a huge improvement. And I don't have that information to try to. So I wish. I'm not quite sure how I'm going to parse this question about is it likely. I'm hopeful that it works and that it will continue to work for patients for 20 years and allow patients to avoid dialysis, but I don't feel like I have that evidence.
Great, thank you. All right, let's vote. We can put the voting question back up. As a reminder, this is for sibeprenlimab. Waiting for one more. So we have 2 for no, 3 for small improvement, and 9 for substantial improvement. Let's move on to the next one. And I think given the discussion will be similar, we can just go ahead and vote on this. Is atacicept likely to improve caregivers' quality of life and or ability to pursue their own education, work, and family life? And please vote. And we have the same vote, 2 for no, 3 for small improvement, and 9 for substantial improvement. Great. So now we're moving on to, NEFCON. Yes. So is NEFCON likely to improve caregivers' quality of life and or ability to pursue their own education, work, and family life? And just as a reminder to folks, the thing that differentiates NEFCON that may have an impact on this is its reduced steroid toxicity. So I think we're probably still, people hopefully are still able to go ahead and vote unless there's anything anyone wants to add. And here we have 1 no, 9 small improvement, and 4 with a substantial improvement. So now we'll go on to the value for money vote. And this is where we'll need Brett's help summarizing some of the information on the price and the long-term value for money. So the question is, just to remind us at the beginning, given the available evidence on comparative clinical effectiveness and incremental cost effectiveness, and considering benefits beyond health and special ethical priorities, the things that we already discussed in the beginning, what is the long-term value for money of sibeprenlimab at current pricing? So Brett.
Yep. So you can look at the base case modeled results in table 7, the incremental cost effectiveness ratios in table 8. And then we have the health price benchmarks in table 12 of your evidence summary. And just to cover the estimate ranges that we came up with for those thresholds for sibeprenlimab and atacicept, that range was about 60 to 80,000 per year. The annual WAC is 390, but remember we used in the model the estimated net price of 292,500 per year for sibeprenlimab. Let's see, any questions on that? Did I skip anything? Anything else you want me to cover there?
Joy.
So the thing that's troubling me about the analysis is not so much the 2 ones that I can't pronounce, but the NEFCON analysis because it was based on 9 months of therapy, right? And that's it. And we're done. And there was a lower effectiveness, I think, related to that. But it's really sounding like from listening to the clinical experts that that's very unlikely how it will be used. So it strikes me that the differences between the three are probably diminished relative to what we're seeing in Table 8.
Observation, yeah.
Just a reminder, though, that we're right now just voting on sibeprenlimab, so you'll get a chance to go there on that. And also, when it comes to it, and I'm sure that Sarah's going to bring this up in the policy roundtable, but the FDA label right now is for a single course, and whether payers, we were just hearing that there was a patient who tried to get a second course, and I think got it, but it's not that easy to get a really expensive drug off label on a repeated basis.
Just since we're talking about it, it seems to me the labeling about sibeprenlimab is also 9 months. Is that correct? Or am
The assumption is it's ongoing.
No, I know that's the assumption. I'm asking about the FDA labeling.
I defer to Jason. But I don't think there's a time constraint on the labeling.
Yeah, I have to look this up. I'm not sure. I don't. That's my assumption too, but I can confirm.
There's no time frame on the label for.
Okay, Jeff.
Thank you. When we're thinking about the value for money, that is with what comparator?
Yeah, the table 12, the benefit price benchmarks are compared to steroids. I think it's really important to point out, because I think this has gotten a little muddied, that we're only modeling against steroids, but we do have the no specific therapy as a scenario. And for sibeprenlimab, it was rounded out to be about the same. So we're in this scenario where steroids really didn't do that much in terms of effectiveness for a patient, but it did cause some harm. So we would expect no specific therapy to essentially have the same difference when we go with sibeprenlimab. So I think that's been kind of lost. And even though we're only presenting against steroids, it's really the same answer.
Thank you.
I think that's a really good point. So I think if I've got it right, what you're saying is if you were to just compare to placebo or something that was Nefcon, that the value for money of this would be even less.
Well, it's shown in the table. So if you look at the scenario analysis table 11 in your evidence summary, you get the same rounded answer, but the numbers are actually different in the model, and you'd be able to see it in like the interactive model or the actual numbers. But the point I'm making is that there's a tiny benefit of steroids that was modeled, like the really, really small incremental benefit. It could probably be considered clinically as non-different. It's just no difference between the two. But the harms from steroids were also modeled, which is also part of the objective of this, right? How much, whether you pick steroids as a comparator or no therapy, we have to model those harms. So the answer for sibeprenlimab specifically was very similar. There really wasn't a difference that's significant enough to even make a comment on, outside of not using steroids and avoiding those side effects.
Great. David?
Yeah, just to Bob's point about not getting too lost in the weeds. If we believe Brett's model, sibeprenlimab is a spectacular drug. It adds huge amounts of quality of life. It adds years of life. It adds years off dialysis. And the problem with it is it costs way too much, despite being a really great drug. If this drug were priced appropriately, it would be spectacular.
And with that, are people ready to vote? to cast your votes. All right, we got 14 votes. So 0 for high long-term value, 2 for intermediate long-term value, and 12 for low long-term value for money at current pricing. And then let's just do the last vote, and then we can see if people have any last comments. So this is given the available evidence on comparative clinical effectiveness and incremental cost effectiveness and considering benefits beyond health and special ethical priorities that we already discussed. What is the long-term value for money of NEFCON at current pricing? And obviously this will be a different scenario than the one we just looked at. So Brett, real quick, do you want to remind us?
Yep. So the answer is also the estimates are available again in table 7 and table 8. And what we found was Nefecon meeting with that one single course, again, like we just talked about, that corresponds to the label. We do see that meeting the upper limit of the cost effectiveness thresholds. Then when we confirm, at least when we kind of collate that evidence with table 12, we see Nefecon pricing meeting those thresholds right around where they're currently pricing for that 9-month course. That's really over the course of 1 year, but the prices are applied as a 9-month price.
Jeff.
Thank you. I just want to make sure I understand your answer to my question this morning, as well as what you just pointed out. You mentioned that the estimate is right at the upper threshold, but did I also understand you correctly that you think there's a 2/3 chance that the real value is actually above that threshold?
Yeah, and a lot of that, the reason I was pointing that out and then demonstrating the wide uncertainty, if you look at table 11, you'll see when we make the assumption in the evidence summary, see that we make the assumption that maybe steroids only have a 2-year impact on adverse effect costs and quality of life. We heard from some clinical experts this usually resolves within a couple of years. And then there's the other scenario where those last for a lifetime. And then that would be a dominant scenario. That is the main driver behind that probabilistic analysis. That is the main driver behind that uncertainty. And back to your question, which was a really good one earlier, that's really what's driving it. It's less about Nefecon and it's more about the comparator. So in this case, the comparison to steroids does matter quite a bit, as opposed to, say, sibeprenlimab. And that's also due to the short course of that treatment.
Other Jeff.
Yeah. So, I mean, the problem is it's right at the upper limit, and I can pretty much guarantee you that this is going to get either redosed or continuous treatment or something. So what would that do if, in fact, it gets used the way most people are suggesting it will be used to those estimates of cost? I'd assume it would make them look more like the other 2 drugs.
It would. The caveat is I don't believe that that's what you're voting on, but maybe maybe David can chime in. I don't want to speak out of order on the voting.
I'm happy to chime in on that. I don't know if David was going to, but yeah, I mean, Brett's right. I mean, we're limited to the information we have from the clinical trials, from the FDA label. It's tough to hypothesize what the future real world evidence would be and then how that might change your judgment of value. So I would say stay focused on what we know from the data, how it was modeled, and what's in the label.
Great. And the modeling just includes one course.
One 9-month course, where the price is applied for 9 months and the effectiveness is applied for 2 years.
Right.
And that we actually have pretty decent evidence from their trial on that, including the manufacturer submitted data. So it's pretty
great. People ready to vote on this one?
I just had a question, or I was hoping, so during my time with CTAF and kind of overall in cost effectiveness research, I've seen the willingness to pay threshold go from 50,000 to 100,000 to 150,000. I guess my question is, how close are we to 200,000? And can you put some, because the willingness to pay threshold or the ICER here is 151,000, right? So it's very close. So I'm just wondering, like, what is the current milieu for willingness to pay thresholds out there?
That's great comment. Sarah, is that something for the roundtable
I'd
or
love
not?
to give a quick, I mean, I'm eating into my
Go for
own
it.
time for the roundtable by doing this. And just because of, there's a philosophy behind this that has a combination of science and data and ethics. And so what we use is the underpinning for how we think about the range for the health benefit price benchmark is tied to the research that says when we pay over that range, for a unit of health gain, we harm unseen people in the healthcare system through higher premiums. They forego care and they have harm up to including death. That is pegged at about 100,000, and we stretch the range to 150,000 for our benchmark price because of all of the other benefits and special ethical priorities that are hard to capture in a cost effectiveness model that are still very important to patients, clinicians, their families when we think about value. So we're not stretched into 200. Those values are there in the report for any decision maker who might think that's the more appropriate threshold, but we anchor between 100 and 150.
Great. Thanks, Sarah. Let's vote. Waiting for two more. So we have 0 for high long-term value for money, 11 for intermediate, and 3 for low long-term value for money. So thank you, everyone. Very looking forward to the roundtable discussion later. We are running a little behind, but I think this was a record number of voting questions for an ICER panel. So we got through it. Great job, team, and great discussion. So yeah, I was just going to say, let's start at 1:20. So you get a 7-minute break as opposed to 10 minutes. And we'll see everyone back then.